Cancers of the colon, rectum and anus Q&A, Part 3. Welcome to today's podcast, where we discuss cancers of the colon, rectum and anus. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of cancers of the colon, rectum and anus. Pause the podcast after each question to attempt answer. Let's begin. Rectal cancer, clinical overview Q&A. Epidemiology question: how many new cases of rectal cancer were diagnosed in the United States in 2023? Answer: an estimated 46,050 new cases of rectal cancer were diagnosed in the United States in 2023. Question: how has the proportion of colorectal cancers occurring in the rectum changed over the past 2 decades? Answer: the proportion of colorectal cancers occurring in the rectum has steadily increased over the past 20 years. Question: what trend has been observed in rectal cancer incidence among people under 50 years old? Answer: there has been a notable increase in rectal cancer among individuals under 50, with an approximate 2% annual rise over the past decade. Clinical evaluation and staging question: what should the initial evaluation of a patient with suspected rectal cancer include? Answer: the initial evaluation should include a cancer-specific history and physical examination, focusing on symptoms such as nausea, vomiting, bloating, constipation, pain, and changes in urinary, sexual, and bowel function. Question: what is the clinical significance of symptoms like nausea, vomiting, bloating, pain, tenesmus, and rectal pain in rectal cancer? Answer: nausea, vomiting, and bloating may indicate bowel obstruction. Pain can suggest nerve involvement, and tenesmus and rectal pain are often associated with low tumors and sphincter invasion. Question: how do medical history, fitness, and frailty impact rectal cancer management? Answer: medical history, fitness, and frailty assessments help guide preoperative optimization, risk stratification, and treatment decisions, including the suitability for preoperative therapies and surgery. Question: why are digital rectal examination and proctoscopy important in the evaluation of rectal cancer? Answer: digital rectal examination and proctoscopy are crucial for assessing tumor location, potential invasion, and for planning further diagnostic workup. Question: what are the essential components to document during tumor assessment in rectal cancer? Answer: it is essential to document the tumor's distance from the anal verge and dentate line, as well as to evaluate for invasion of surrounding structures. Question: when is a biopsy necessary in rectal cancer evaluation, and what additional analysis should be performed? Answer: a biopsy is required if invasive glandular cancer is not yet confirmed, and immunohistochemical analysis for mismatch repair protein expression should be performed. Question: which routine laboratory test should be included in the initial assessment of rectal cancer? Answer: a baseline carcinoembryonic antigen level should be obtained as part of the routine laboratory evaluation. Question: why should patients with rectal cancer undergo a complete colonoscopic evaluation? Answer: complete colonoscopy is necessary to assess for the presence of additional cancers or premalignant neoplastic lesions in the colon. Question: what is the reported incidence of synchronous cancers and premalignant neoplastic lesions in rectal cancer patients? Answer: the reported incidence is approximately 3% for synchronous cancers and 30% for premalignant neoplastic lesions. Question: how should the colon be evaluated if a tumor is obstructing and prevents complete colonoscopy? Answer: computed tomography colonography can be used to assess the proximal colon when a tumor obstructs the passage of a colonoscope. Question: when should repeat colonoscopy be considered in patients with rectal cancer? Answer: repeat colonoscopy can be performed after preoperative therapy if the tumor size has decreased and allows for complete evaluation. Question: what is the recommendation for colonoscopy if it cannot be completed before surgery? Answer: colonoscopy should be scheduled for the early period after surgery if it was not possible preoperatively. Question: what staging system should be used to stage rectal cancers before treatment? Answer: rectal cancer should be staged using the American Joint Committee on Cancer Tumor (NOTE) metastasis system prior to the start of treatment. Question: what imaging is recommended to assess for metastatic disease in rectal cancer? Answer: contrast-enhanced computed tomography of the chest, abdomen, and pelvis is recommended to evaluate for the presence of metastatic disease. Question: what is the preferred imaging modality for locoregional staging of rectal cancer? Answer. Pelvic magnetic resonance imaging is the preferred modality to determine tumor and nodal stage, as well as to evaluate tumor location and potential invasion. Question. What is the role of the Multidisciplinary Tumor Board in rectal cancer care? Answer. Multidisciplinary Tumor Board review is essential for determining the best treatment plan, involving input from experts in various fields. Question. How is the decision made regarding the choice between surgery and preoperative therapy in rectal cancer? Answer. The multidisciplinary board decides whether surgery or preoperative therapy is more appropriate based on individual patient factors. Question. Why is multidisciplinary tumor board review considered a quality metric in rectal cancer care? Answer. Participation in multidisciplinary tumor board review is a key quality metric, reflecting the standard of care for rectal cancer management. Treatment modalities. Question. How has the treatment of rectal cancer evolved over time? Answer. Treatment for rectal cancer has advanced significantly over recent decades, leading to improved patient outcomes. Question. What was the historical standard surgical treatment for rectal cancer, and what were its limitations? Answer. The historical standard was abdominoperineal resection, which was associated with high rates of complications and tumor recurrence. Question. What are the outcomes of modern rectal cancer treatment compared to historical treatment? Answer. Modern treatments have resulted in significant improvements, including lower rates of local recurrence. Question. What is the recommended approach to rectal cancer treatment today? Answer. A multidisciplinary approach involving surgeons, oncologists, radiation oncologists, radiologists, and pathologists is recommended. Question. What stages are included in the treatment timeline for rectal cancer? Answer. The timeline includes initial presentation and diagnosis, treatment, ongoing surveillance, and survivorship. Preoperative therapy. Question. What is the role of preoperative radiotherapy in rectal cancer? Answer. Preoperative radiotherapy is evaluated for reducing local recurrence rates in locally advanced tumors that are located in the extraperitoneal portion of the rectum. Question. What did the German rectal cancer study investigate? Answer. The German rectal cancer study compared preoperative and postoperative long-course chemoradiotherapy in 823 patients with clinically staged locally advanced rectal cancer. Question. What are the benefits of preoperative therapy in rectal cancer based on clinical trials? Answer. Preoperative therapy resulted in a significantly lower 5-year local recurrence rate and lower risk of severe toxicities compared to postoperative therapy. Question. What became the standard of care for locally advanced rectal cancer in the United States? Answer. Preoperative chemoradiotherapy became the standard of care for locally advanced rectal cancer. Question. What is the total preoperative therapy approach in rectal cancer? Answer. Total preoperative therapy is a treatment strategy where all chemotherapy and radiotherapy are given before surgery. Question. What benefits does total preoperative therapy offer? Answer. Total preoperative therapy has shown promising results, including improved disease-free survival, higher rates of complete pathologic response, and increased rates of completing chemotherapy. Question. What are the goals of total preoperative therapy in rectal cancer? Answer. The goals are to optimize local control, reduce distant tumor recurrences, and increase overall survival. Question. What did the PRODIGE-23 trial compare in rectal cancer treatment? Answer. The PRODIGE-23 trial compared traditional long-course preoperative chemoradiotherapy with total preoperative therapy using a chemotherapy regimen called FOLFIRINOX and chemoradiotherapy. Question. What were the results of the total preoperative therapy arm in the PRODIGE-23 trial? Answer. The total preoperative therapy arm showed superior 3-year disease-free survival, higher rates of survival without metastasis, and increased rates of complete pathologic response. Question. How did the treatment completion rates compare between study arms in the PRODIGE-23 trial? Answer. 81% of patients in the total preoperative therapy arm completed chemotherapy, compared to 75% in the standard therapy arm. Question. What treatment strategies were compared in the RAPIDO trial for rectal cancer? Answer. The RAPIDO trial compared short-course radiotherapy followed by chemotherapy and surgery, with long-course radiotherapy followed by surgery and post-operative therapy in patients with locally advanced rectal cancer. Question. What treatment did patients in the experimental arm of the RAPIDO trial receive? Answer. Patients in the experimental arm received short-course radiotherapy followed by 6 cycles of chemotherapy with capecitabine and oxaliplidine, or 9 cycles of fluorouracil, leucovorin, and oxaliplidine, prior to total mesorectal excision surgery. Question: what was the standard of care treatment for the comparison group in the RAPIDO trial? Answer: the standard of care group received long-course radiotherapy followed by total mesorectal excision surgery and post-operative therapy. Question: how did the treatment failure rates compare in the RAPIDO trial? Answer: the treatment failure rate was lower in the experimental group at 23.7%, compared to 30.4% in the standard of care group. Question: what accounted for the reduction in treatment failure in the RAPIDO trial? Answer: the reduction in treatment failure was mainly due to a decrease in distant metastasis. Question: what is the current guideline recommendation regarding total preoperative therapy in locally advanced rectal cancer? Answer: the current recommendation is to consider total preoperative therapy as a standard of care preoperative treatment for patients with locally advanced rectal cancer. Organ preservation. Question: what triggered interest in non-operative management of rectal cancer? Answer: the observation that 20 to 25% of patients achieved a complete pathologic response after preoperative therapy led to interest in non-operative management. Question: what did Professor Haber-Gama's group report in 2004 regarding non-operative management? Answer: the group published long-term outcome data showing that patients with complete clinical response managed without surgery had excellent survival and disease-free outcomes under close observation. Question: what were the 5-year outcomes for patients in the watch and wait protocol after preoperative therapy? Answer: 5-year overall survival was 100%, and disease-free survival was 92%. Question: how do recent guidelines advise clinicians to approach non-operative management in rectal cancer? Answer: recent guidelines recommend a selective approach to non-operative management for patients who achieve a complete clinical response after preoperative therapy. Question: what restaging procedures are necessary to confirm a complete clinical response after preoperative therapy for rectal cancer? Answer: comprehensive restaging should include computed tomography scan of the chest and abdomen, magnetic resonance imaging of the pelvis, and digital rectal examination with flexible proctoscopy. Question: how is a complete clinical response defined in rectal cancer after preoperative therapy? Answer: it is defined by the absence of a mass or nodularity on digital rectal examination, the presence of a smooth scar on endoscopy, and no mass or lymph nodes on magnetic resonance imaging. Question: what is the significance of a complete clinical response in rectal cancer? Answer: a complete clinical response indicates no clinical evidence of cancer after treatment, though microscopic cancer cells may still be present. Question: what does surveillance for patients managed without surgery following a complete clinical response involve? Answer: surveillance includes regular digital rectal examination, carcinoembryonic antigen measurements, magnetic resonance imaging, and computed tomography scans for at least 5 years. Question: what are typical magnetic resonance imaging findings in patients with a complete clinical response after rectal cancer therapy? Answer: magnetic resonance imaging may show a fibrotic scar with low signal intensity on T2 weighted imaging and no restriction of diffusion. Question: what was the objective of recent trials regarding therapy sequence in locally advanced rectal cancer? Answer: the objective was to determine the optimal sequence of therapies for locally advanced rectal cancer, comparing induction chemotherapy followed by chemoradiation, and chemoradiation followed by consolidation chemotherapy. Question: what were the 3-year disease-free survival rates in recent studies of rectal cancer therapy sequence? Answer: both treatment arms showed a 3-year disease-free survival of 76%. Question: how did organ preservation rates compare between consolidation chemotherapy after chemoradiation and induction chemotherapy before chemoradiation? Answer: chemoradiation followed by consolidation chemotherapy resulted in higher complete clinical response and 3-year organ preservation rates, 53%, compared to induction chemotherapy followed by chemoradiation, 41%. Question: what happens to patients with tumor regrowth during non-operative surveillance? Answer: patients with tumor regrowth during surveillance proceed to surgery, and this does not negatively impact survival. Surgical anatomy and principles. Question: why is high-quality surgery important in rectal cancer treatment? Answer: High-quality surgery is vital for rectal cancer management and requires a thorough understanding of rectal and pelvic anatomy. Question: how is the distal rectum defined anatomically? Answer: the distal rectum is defined by the anorectal ring, which is the upper border of the anal sphincter and puborectalis muscles. Question: what challenges exist in defining the proximal rectum? Answer: the proximal rectum is more difficult to define due to variations in the peritoneal reflection and distance from the anal verge, but is generally considered the junction of the sigmoid mesocolon and mesorectum. Question: which arteries supply blood to the rectum? Answer: the rectum is supplied by the superior rectal artery, a branch of the inferior mesenteric artery, and the middle and inferior rectal arteries, branches of the internal iliac artery. Question: how is venous drainage of the rectum managed during surgery? Answer: venous drainage occurs via the inferior mesenteric vein, which is often ligated during low rectal resections to facilitate a tension-free bowel connection. Question: how does lymphatic drainage of the rectum vary by location? Answer: the upper two-thirds of the rectum drain to inferior mesenteric nodes, the lower third to both inferior mesenteric and internal iliac nodes, and regions below the dentate line to inguinal nodes. Question: what is the significance of high versus low ligation of the inferior mesenteric artery in rectal cancer surgery? Answer: high ligation, performed proximal to the left colic artery, is common but has not shown improved outcomes compared to low ligation just distal to the left colic artery. Question: what is a benefit of distal ligation of the inferior mesenteric artery? Answer: distal ligation reduces the risk of nerve injury during surgery. Question: when should lateral pelvic node dissection be considered in rectal cancer? Answer: lateral pelvic node dissection is considered for distal rectal cancers with suspicious lateral pelvic lymph nodes identified on preoperative magnetic resonance imaging. Question: how has the recognition of fascial planes affected rectal cancer surgery? Answer: recognizing fascial planes in the pelvis has revolutionized rectal cancer surgery, improving both cancer outcomes and preservation of function. Question: what is the endopelvic fascia and its significance in rectal surgery? Answer: the endopelvic fascia lines the pelvis and internal organs, serving as a visceral fascia important for surgical dissection. Question: what is the mesorectum, and why is it important in rectal cancer surgery? Answer: the mesorectum is a fatty tissue envelope surrounded by a thin fascial layer, containing terminal branches of the inferior mesenteric artery and rectal lymphatics, which are removed during total mesorectal excision. Question: what does total mesorectal excision involve? Answer: total mesorectal excision involves removing the rectum together with the mesorectum, including associated blood vessels, lymphatics, and lymph nodes. Question: why is the correct plane of total mesorectal excision important? Answer: performing total mesorectal excision in the correct anatomical plane significantly improves long-term cancer outcomes. Question: what are the risks of traditional blunt dissection compared to total mesorectal excision? Answer: traditional blunt dissection is associated with a 25% rate of positive circumferential resection margins, and high recurrence and mortality rates. Question: how does total mesorectal excision impact local recurrence and survival rates? Answer: total mesorectal excision reduces local recurrence from 12% to 6% and increases survival rates to 73% compared to 60% with conventional surgery. Question: what complications can occur if dissection is performed outside the total mesorectal excision plane? Answer: dissection outside the correct plane can cause severe bleeding from the presacral venous plexus, which may be difficult to control. Question: what should be done if the circumferential resection margin remains involved after preoperative therapies? Answer: dissection beyond the total mesorectal excision plane may be needed for negative margins, possibly requiring removal of adjacent organs as a single unit. Question: what is the importance of sharp dissection in rectal cancer surgery? Answer: sharp dissection in the correct total mesorectal excision plane ensures complete cancer removal and protects autonomic nerves. Question: what are the sources of sympathetic and parasympathetic nerve supply to the rectum? Answer: the sympathetic supply originates from the first, second, and third lumbar spinal segments, forming the hypogastric plexus for the upper rectum. The parasympathetic supply originates from the second, third, and fourth sacral spinal segments, joining the sympathetic nerves at the pelvic plexus to form the nerves for erection. Question: what are the risks of nerve injury during rectal cancer surgery? Answer: Injury to the hypogastric plexus can cause retrograde ejaculation in males, while injury to the pelvic plexus and nerves for erection can result in erectile dysfunction, impotence, and loss of bladder tone. Question: what are the recommended margins for upper rectal and rectosigmoid tumors during dissection? Answer: a margin of 5 cm distal to the tumor is recommended. Question: how should the mesorectum be managed in rectal cancer resections? Answer: partial or tumor-specific mesorectal excision is performed, thinning the mesorectum to the bowel wall at least 5 cm distal to the tumor. Question: what is the importance of the fascia propria in rectal cancer surgery? Answer: the fascia propria of the rectum should not be violated around the tumor to ensure oncologic safety. Question: what is abdominoperineal resection, and when is it indicated? Answer: abdominoperineal resection is a surgical procedure involving removal of the rectum, anus, and sphincter apparatus, performed when the tumor involves the sphincter. Question: what are the steps in the abdominoperineal resection procedure? Answer: the procedure involves both abdominal and perineal approaches for complete removal of the rectum and sphincter complex. Question: when is end-colostomy indicated in rectal cancer surgery? Answer: end-colostomy, performed through abdominal and perineal approaches, is indicated for patients with poor sphincter function. Question: what are important technical considerations during abdominoperineal resection? Answer: careful dissection is necessary to avoid narrowing the specimen, and the anus and sphincter must be removed together, with closure of the perineum. Question: how can post-operative wound complications be reduced after rectal cancer surgery? Answer: omental pedicle flaps and rotational tissue flaps can be used to fill the pelvic space and reduce perineal wound complications. Sphincter preservation and bowel function. Question: how is the decision to preserve the sphincter made in rectal cancer surgery? Answer: the decision is made jointly with the patient before surgery, considering factors such as tumor location, surgical margins, and the patient's overall health. Question: what is the preferred distal margin for rectal tumor resection, and are there exceptions? Answer: a 2 cm distal margin is generally preferred, but margins less than 1 cm may be acceptable for low rectal tumors after preoperative therapy. Question: what patient factors should be considered when planning sphincter-preserving surgery? Answer: age, comorbidities, body habitus, continence status, and patient preferences should be taken into account. Question: what is the risk associated with very close distal margins in rectal cancer surgery? Answer: there is a higher risk of local recurrence, especially in tumors that respond poorly to preoperative therapy. Question: why is it sometimes difficult to determine sphincter involvement after preoperative therapy? Answer: it can be challenging to distinguish between fibrosis and residual tumor, so sphincter involvement is often assumed in equivocal cases. Question: in which patients is sphincter preservation not an option? Answer: sphincter preservation is not possible in patients with involvement of the levator or external anal sphincter muscles. Question: who are suitable candidates for low anterior resection with intersphincteric resection? Answer: motivated patients with only internal sphincter involvement can undergo low anterior resection with intersphincteric resection and Hanson colonal anastomosis. Question: what should patients be informed about regarding functional outcomes after sphincter-preserving surgery? Answer: patients should be counseled about the possibility of increased fecal incontinence and other changes in bowel function. Question: who are unsuitable candidates for low anterior resection with a low stapled anastomosis? Answer: patients with poor preoperative anal sphincter function or bowel habits are not suitable and may benefit from a permanent colostomy. Question: what is low anterior resection syndrome? Answer: low anterior resection syndrome is a group of symptoms, including increased bowel frequency, urgency, and clustering, experienced by most patients after low anterior resection. Question: what are risk factors for low anterior resection syndrome? Answer: risk factors include female sex, preoperative therapy, total mesorectal excision, and low tumors. Question: how can bowel function be improved after ultra-low anterior resection? Answer: creating a colonic J-pouch or side-to-end anastomosis can improve bowel function during the first 1 to 2 years after surgery. Use of a diverting ileostomy. Question: what are the benefits of a diverting loop ileostomy in rectal cancer surgery? Answer: a diverting loop ileostomy reduces clinical anastomotic leaks and the need for reoperation in patients undergoing low anterior resection. Question: What are the drawbacks of a diverting loop ileostomy? Answer. It is associated with increased stoma-related complications, such as dehydration. Question. What are risk factors for anastomotic leak in rectal cancer surgery? Answer. Risk factors include low rectal anastomosis, male sex, and preoperative radiotherapy. Question. When should a diverting loop ileostomy be strongly considered? Answer. It should be strongly considered for patients at increased risk of anastomotic leak. Question. What preoperative counseling is recommended for patients who may require an ileostomy? Answer. Patients should be counseled by a trained wound, ostomy, and continence nurse for preoperative education and marking of the stoma site. Role of local excision. Question. What surgical advancements have allowed for the removal of large rectal tumors by local excision? Answer. Transanal endoscopic microsurgery and transanal minimally invasive surgery enable the removal of large rectal tumors. Question. What is the benefit of these local excision procedures? Answer. These procedures allow for the removal of tumors with negative margins, confirming that the cancer has been completely excised. Question. For which patients is local excision appropriate in rectal cancer management? Answer. Local excision is suitable for highly selected patients with clinically staged early tumors without high-risk features for hidden lymph node metastases. Question. What is a limitation of local excision for rectal cancer? Answer. Local excision does not remove or allow for pathologic staging of mesorectal lymph nodes. Question. What are high-risk features for hidden lymph node metastases in rectal cancer? Answer. High-risk features include deep invasion, poor tumor differentiation, lymphovascular and perineural invasion, tumor budding, and positive surgical margins. Question. How should local excision specimens be managed for accurate pathology? Answer. Tumors should be removed in one piece with a normal circumferential margin, and the specimen should be fixed and oriented for precise histologic assessment. Question. What is recommended for patients with high-risk features on final pathology following local excision? Answer. Medically fit patients should be counseled about the risks of local recurrence and lymph node metastasis, and a formal oncologic total mesorectal excision should be recommended. Question. How might organ preservation criteria be expanded in rectal cancer management? Answer. Preoperative chemotherapy followed by transanal local excision shows potential for expanding organ preservation criteria in early to mid-stage tumors without compromising cancer outcomes. Minimally invasive total mesorectal excision. Question. What are the benefits of minimally invasive surgery for rectal cancer? Answer. Minimally invasive surgery improves short-term outcomes and speeds up recovery for rectal cancer patients. Question. How do oncologic outcomes of laparoscopic total mesorectal excision compare to open surgery? Answer. Randomized controlled trials have not shown laparoscopic total mesorectal excision to be superior to open surgery in terms of cancer outcomes. Question. What technical challenges are associated with minimally invasive total mesorectal excision? Answer. The main challenges are achieving negative resection margins and obtaining an intact mesorectum during the procedure. Question. When is minimally invasive total mesorectal excision recommended? Answer. Minimally invasive total mesorectal excision can be considered, but should only be performed by surgeons with significant technical expertise. Adjuvant therapy. Question. Should patients with stage 2 or 3 disease who received total preoperative therapy receive further chemotherapy? Answer. Patients with pathologic stage 2 or 3 disease who received total preoperative therapy should not receive additional chemotherapy after surgery. Question. What is the recommendation for patients who did not complete the full course of preoperative chemotherapy? Answer. Patients with clinical or pathologic stage 2 or 3 tumors who did not receive a full course of preoperative chemotherapy are usually advised to receive chemotherapy after surgery. Question. What chemotherapy regimen is preferred for adjuvant therapy in rectal cancer? Answer. The National Comprehensive Cancer Network recommends regimens containing oxaliplatin and fluorouracil, such as 8 cycles of fluorouracil, leucovorin, and oxaliplatin, except for clinical stage 3, node-negative patients. Question. When is post-operative radiotherapy recommended for rectal cancer? Answer. Post-operative radiotherapy is recommended for patients with stage 2 or 3 cancers who did not receive preoperative radiotherapy and are at increased risk for local recurrence. Question. What is a consideration when recommending post-operative radiotherapy? Answer. Clinicians must consider the potential risk of pelvic radiation negatively affecting bowel function and wound healing after surgery. Management of rectal cancer with synchronous metastases. Question: what percentage of rectal cancer patients are diagnosed with metastatic disease at the same time as their primary diagnosis? Answer: approximately 20% of rectal cancer patients are diagnosed with metastatic disease at the same time as their primary tumor. Question: what are the most common sites of metastasis in rectal cancer? Answer: the liver is the most common site of metastasis, followed by the lungs. Question: how does surgical treatment impact outcomes for patients with stage 4 colorectal cancer? Answer: retrospective studies show that surgical treatment is associated with better outcomes in stage 4 colorectal cancer patients. Question: why is it important to assess the resectability of metastatic disease in rectal cancer? Answer: assessing resectability is critical for planning treatment and should be performed in a multidisciplinary setting. Question: what are the criteria for resecting metastatic disease in rectal cancer? Answer: metastatic disease is considered resectable if all known tumors can be removed with negative margins while preserving adequate organ function. Question: what is the recommended treatment for patients with unresectable metastases? Answer: systemic chemotherapy is recommended to extend survival in patients with metastases that cannot be surgically removed. Question: when are palliative interventions considered in rectal cancer with metastatic disease? Answer: palliative interventions are strongly considered for symptomatic patients even when metastases are unresectable. Question: what palliative options are available for symptomatic rectal cancer patients with metastases? Answer: options include radiotherapy, stent placement, fecal diversion, or removal of the primary tumor, depending on symptoms and prognosis. Question: how should decision-making be approached in the management of metastatic rectal cancer? Answer: decision-making should be shared among a multidisciplinary team, considering morbidity, efficacy, and the impact on ongoing chemotherapy. Question: what is the recommended initial treatment for patients with resectable or potentially resectable liver metastases from rectal cancer? Answer: 3 to 4 months of systemic therapy is recommended to assess disease biology, facilitate surgical resection, and reduce the risk of early recurrence. Question: what are the risks associated with oxaliplatin and irinotecan in preoperative chemotherapy for rectal cancer with liver metastases? Answer: these chemotherapy agents can cause liver injury, which may affect liver function after resection. Question: what surgical approaches are considered for patients with rectal cancer and liver metastases? Answer: surgical options include combined, simultaneous, resection of both primary and metastatic disease, a rectum-first approach, or a liver-first approach, depending on various clinical factors. Question: for which patients is the combined approach to resection preferred? Answer: the combined approach is favored for healthy patients with upper rectal tumors and liver metastases that do not require major liver resections. Question: what is the recommended treatment for low rectal tumors with threatened circumferential resection margins? Answer: short-course radiotherapy is strongly recommended to reduce the risk of local recurrence and minimize interruption of systemic chemotherapy. Immunotherapy. Question: how has immunotherapy impacted outcomes for colorectal cancer with mismatch repair deficiency or high microsatellite instability? Answer: immunotherapy using checkpoint inhibitors has significantly improved outcomes for these patients in the setting of metastatic disease. Question: what is the current recommendation for checkpoint inhibitor therapy in stage 4 rectal cancer patients with mismatch repair deficiency or high microsatellite instability? Answer: checkpoint inhibitors are well established as a first-line therapy in this patient population. Question: what is the prevalence of mismatch repair deficiency in rectal cancer? Answer: approximately 3 to 7% of rectal cancer patients have mismatch repair deficiency. Question: how effective is preoperative immunotherapy in mismatch repair deficient rectal cancer? Answer: preoperative immunotherapy has shown dramatic responses, with some studies reporting a 100% complete clinical response rate. Question: what are the implications of a high complete clinical response rate to immunotherapy in mismatch repair deficient rectal cancer? Answer: this finding suggests the potential to avoid subsequent chemoradiotherapy or surgery in these patients. Question: why is long-term follow-up important for patients treated with immunotherapy for mismatch repair deficient rectal cancer? Answer: long-term follow-up is necessary to determine the durability of response and assess the risk for new, Separate cancers. Question. How might prospective trial data influence future treatment approaches for mismatch repair deficient locally advanced rectal cancer? Answer. Data from ongoing trials will likely shape future preoperative treatment strategies for these patients. Pathologic staging and prognosis. Question. Why is pathologic assessment and staging important after rectal cancer surgery? Answer. Pathologic assessment and staging are crucial for determining prognosis and risk stratification following surgery. Question. What protocols are used for examining colon and rectal cancer specimens? Answer. The College of American Pathologists provides specific protocols for examining these specimens. Question. How does the synoptic pathology report contribute to rectal cancer care? Answer. The synoptic pathology report standardizes documentation for rectal cancer specimens, ensuring all relevant features are recorded. Question. What critical findings are included in the rectal cancer pathology report? Answer. The report includes the integrity of the mesorectum, tumor relationship to the peritoneal reflection, and tumor regression grade. Question. What is the significance of tumor regression grade in rectal cancer pathology? Answer. Tumor regression grade, ranging from 0 to 3, reflects the pathologic response to preoperative therapy, with 0 indicating complete response and 3 indicating no effect. Question. When should mismatch repair deficiency be assessed in rectal cancer specimens? Answer. Immunohistochemistry for mismatch repair proteins should be performed on the resected specimen if not already done on the initial biopsy. Question. How does tumor genomic sequencing guide therapy in metastatic rectal cancer? Answer. Tumor genomic sequencing can help select targeted therapies for metastatic disease. Question. What are the most accurate predictors of survival and recurrence in locally advanced rectal cancer? Answer. Post-treatment pathologic stage and tumor regression grade are more accurate predictors than clinical stage at presentation. Question. What is the prognosis for patients with complete pathologic response after preoperative therapy? Answer. Patients with complete pathologic response have the best prognosis, with 5-year overall survival rates of approximately 90%. Question. What factors predict survival after margin-negative rectal cancer resection? Answer. Predictive factors include post-treatment tumor and nodal stage, tumor regression grade, tumor distance from the anal verge, lymphovascular invasion, and perineural invasion. Post-operative surveillance. Question. What is the primary goal of post-operative surveillance in rectal cancer patients? Answer. The main goal is early identification of potentially curable recurrences and detection or prevention of new, separate cancers. Question. What is the recommended surveillance regimen after rectal cancer surgery? Answer. Regular clinical evaluations, carcinoembryonic antigen measurements, cross-sectional imaging, and colonoscopies should be performed for at least 5 years. Question. What additional surveillance is recommended for high-risk rectal cancer patients? Answer. High-risk patients should undergo proctosigmoidoscopy every 6 months for at least 2 years, in addition to pelvic magnetic resonance imaging or endoscopic ultrasound. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.